Yeah. Is it? It's not working. No, it's not working. So that's fine. So as I said, I have to bother you again, and it's my task to discuss with you the endoscopic drainage opportunities that a gastroenterologist, who is at the same time an endoscopist, has in the treatment of perihilar tumors. Now, I would like just to give you the presentation in a way to show to you what kind of what armamentarium the gastroenterologist has to deal with perihilar tumor and what kind of options he can offer in the treatment and diagnosis of a perihilar tumor. Now, this is a list of options that we have. Surgical bypass is for sure something that the surgeon can offer. We should not do that regularly because a gastroenterologist has options to treat biliary obstruction. This is in most of the cases the scenario when we transfer a patient to the surgical department for resection of perihilar tumor, and during the surgery it turns out that resection is not possible. Then a surgeon usually places, not usually, but most of the cases place a biliary digestive anastomosis. The gastroenterologist has many other options. He has the option of endoscopic drainage, either via ERCP, or if the papilla is not accessible, via EUS-guided biliary drainage. He has the option of percutaneous drainage. This is something that maybe is special for Germany because the gastroenterologists also do PTCD or PTBD, which is not the case in many other countries because the radiologist will take over. We can offer also via endoscopy local ablative measurements like PDT, RFA or PCI, which I will talk about in a few minutes. And of course, this is also something special for Germany. We as gastroenterologists are also GI oncologists, so a gastroenterologist can also offer systemic chemotherapy, gemcitabine, cisplatin, or irinotecan. Now, in most of the cases, a patient is transferred to the hospital with jaundice, and the first doctor that usually sees these patients is the gastroenterologist because of jaundice. And what a gastroenterologist should do in addition to the endoscopic interventions is, of course, to ask the patient about symptoms and about his history. So whether or not he's suffering from pain or he has itching or looks like being yellowish, jaundice. And he also has to add some lab values like bilirubin or liver function test. This is the primary care of a gastroenterologist that he has to do when he is confronted with a patient with jaundice. And the second thing that he has to do is an abdominal ultrasound. Very easy and quick technique, but give you fundamental information in terms of whether or not the bile duct is dilated or not dilated. If the bile duct is not dilated, you need another workup, ruling out autoimmunological disorders in the liver. But if the bile duct is dilated and you do not see any evidence of calculi, as a gastroenterologist, you can offer EUS, which is also a very important tool in the differential diagnosis of jaundice with biliary obstruction. What you should not do, and I think all the surgeons who are sitting here will agree with me, you should not do ERCP in a patient with bile duct obstruction, intrahepatic, before doing MRI or CT scan. But EUS is possible. It gives you information, either impacted calculi that you cannot see in the abdominal ultrasound or something else. And this is a case that occurred in our hospital with a patient with jaundice and with bile duct obstruction, but without evidence for reason. So what we did is we did EUS, and I hope the video is working. And you can see, and hopefully you can see because of the light, this is the pancreatic duct popping up. And then above you will see the bile duct. Here is the bile duct, and this is a lesion that leads to obstruction of the bile duct, very distal and not evident in abdominal ultrasound. And if you see such a lesion, you can also offer contrast enhancement, shown here on the right-hand side. You can see that this lesion is not taking up the contrast agent. So this is a way to show you that an endoscopic ultrasound is very helpful in the differential diagnosis of jaundice. And then, after having seen the EUS, it was very easy to complement our finding with another imaging technique. What we did is in CT scan, and in the CT scan, you can see here, there is an obstruction of bile duct. We didn't need any further management. That was clear. This patient has to be sent to the surgical department for Whipple resection, and it turned out to be a distal biliary cancer. So EUS is a good tool for diagnosis, particularly in cases where you do not really see the reason for biliary obstruction in the abdominal ultrasound. The next tool that the gastroenterologist can offer to help with the drainage of a patient with jaundice and perihilar tumor is ERCP. Of course, you have to be trained to be able to do ERCP, and we know from old studies that if you do ERCP, you should try to achieve the best drainage possible. It is not reasonable to do opacification with contrast agent and you are not able to have a drainage. This study has shown that if both lobes are opacified, but you are not able or not willing to drain both of them, only one, the outcome is the worst. So biliary drainage with plastic stent is possible and can prolong survival in patients with Klatskin tumors, perihilar tumors. But if you do ERCP and you have the opacification of the segments, you should try to drain them, because those patients who had opacified both lobes and drained both lobes had the best outcome, meaning that optimal stenting of all cholangiographic opacified lobes results in a better survival, also shown here in the graph. So as a gastroenterologist doing endoscopy, you can offer drainage, but you should do it properly, and you should not try to opacify all lobes and then not being able to offer drainage, because that will deteriorate the outcome in these patients. Now, the other option that a gastroenterologist has is a PTBD. So as I said, we in the gastroenterology department do PTBD or PTCD, and given the fact that there is not really a good meta-analysis on palliative placement of PTCD in patients with perihilar tumors, this is a meta-analysis put together from different studies that were done on resectable perihilar cholangiocarcinoma. And this meta-analysis of these different non-randomized controlled trials showed that there is no big difference in technical success rate in our zero resection in these patients with, as I said, resectable perihilar tumor, and that the incidence of total complication after resection is not different. The postoperative hospitalization time was the same, as well as the resection time and recurrence. However, a very recent study published last year from the Netherlands has shown also in patients that with resectable cholangiocarcinoma that it seems also not significant. The study did not really reveal a difference between these two procedures, but that is something that needs to alert us. The complication rate with death was higher in the PTBD group, suggesting that both are equally good, but it seems that the PTBD, at least in not really trained hands, could have more complications. Now, there is another, the technology is going on, and as a gastroenterologist, we are also trying to perform better, to improve our technique. And this is something that is very interesting and coming up in most of the department, is the so-called EUS-guided biliary drainage. If you are not able to enter the papilla via ERCP because of the tumor, you can do it either via EUS-guided puncture of the distal ductus choledochus. You are trying to puncture from the duodenal bulb the bile duct that is dilated and place a stent not via the papilla but via the puncture of the bile duct. Or what is also possible, you can enter the left lobe from the stomach, which is called hepatogastrostomy. And this is something that is possible. You can place stents, as shown here, from the stomach to the left lobe. This is, as if you want to have the terminology, an internal PTCD. But this is something you should never do in a patient with resectable perihilar cholangiocarcinoma. This is something that you can offer to patients that are palliative and not resectable. But this is a technique that is moving forward and can be offered in the management of palliative treatment of perihilar cholangiocarcinoma. And of course, as it is always with the new technologies, you have to learn these technologies, to implement these technologies in your hospital, and the complications rate are not neglectable. They are there, and the better or the more often you do this technique, the better you will be. And this is a retrospective single-center analysis of a center that has done many of these procedures. The technical success is much better if you can also place not only a metal stent, you can use this technology also to place a wire and then remove the wire and placing a stent like for the ERCP. So it seems that it is possible, but the complications are there, about 26 to 10%. And the stent patency with chemotherapy seems to be higher in the hepatogastrostomy with antegrade stenting for malignant biliary obstruction. So this is a good technology, but as I said, this is something that comes up and needs to be implemented in the centers. And of course, you need to have more experience in that. So there is a meta-analysis when it comes to what kind of stent should we place in a patient with biliary obstruction. I know there is always a big discussion, should we put a plastic stent, should we put a metal stent? Of course, in those cases where the placement of a metal stent is possible. So it seems that based on 13 randomized clinical trials comparing metal stent, SEMS 10 millimeter versus plastic stent 10 French, it seems that the dysfunction rate is higher in the plastic state with close to 50%. The lower rate of intervention is significantly lower in the metal stent. I mean, this is something that everybody can appreciate. And it seems that there is no difference in complication. Median overall survival seems to be better in those patients that received a metal stent due to biliary obstruction. And the patency rate was higher in the metal stent patient with 250 days versus 124 days. So it seems to be doubling in this metal stent group. And the overall cost per rate are not higher in the metal stent group. You have to consider that a plastic stent has to be rechanged every 3 months, which is not true for metal stents, which you have to change after 7 to 9 months. So it seems it's cost effective to place a metal stent in a patient with biliary obstruction in a palliative setting. So there was another issue, should we use covered or uncovered metal stent? For all those who are gastroenterologists among the audience, they know that there is this discussion, should we use a covered or non-covered metal stent? This issue has also been more or less solved. We know that covered and uncovered metal stent, that there is not a real big difference when it comes to hemorrhage, cholecystitis, because some gastroenterologists were concerned through the placement of a covered metal stent, they can obstruct the cysticus duct and can induce cholecystitis. This seems not to be the case. also retroperitoneal perforation is not different in cholangitis also. So arguing that there is not a big difference when it comes to covered versus not covered metal stent. Of course, if you have metal stent, you have the option to cover these stents not only with a plastic, but also with drugs. We know these drug-eluting stents from the cardiologists. They place drug-eluting stents in the coronary artery. So is this something that we also need to consider for biliary duct obstruction? You can cover these metal stents with chemotherapeutic agents like paclitaxel and try to have also a local anti-tumor effect in biliary obstruction due to tumor. And this graph shows that it is possible to do such stents, but the benefit of these stents for patients with perihiler or distal cholangiocarcinoma is not really evident. Even more, it seems that those who received a paclitaxel-coated metal stent had a worse patient survival compared to those who had only a bare metal stent, so to say. So there is not a big difference. It seems that those with drug-eluting stent had a worse outcome, which was not significant. Of course, technology is developing, and as a gastroenterologist, we can offer the patients a photodynamic therapy, which is a sophisticated tool not only for the gastroenterologist, but also for the patients. The technology behind the photodynamic therapy is you apply a substance which is a photosensitizer, like a poriferm, shown here, at a specific dosage. And this photosensitizer can be activated through a specific laser with a specific wavelength. And the activation of this photosensitizer, shown here on the graph, results in the accumulation of oxygen radicals that may or may not kill the tumor cell. So this is the background of this technology called photodynamic therapy. As I said, this is a sophisticated tool shown here. This is the laser. You have to prepare the patient. They have to get the photosensitizer 48 hours before the intervention. And also for the patients, the same way, because they have to wear sunglasses, because these photosensitizers accumulate in all the cells in the body and can, of course, sensitize every single cells to UV light. So this is something that you should not do in summer times, because this is not really good for the patient. So it's a good technology with a rational background, which is really interesting, but as I said, not really fancy for the patients. It induces, as I said, through accumulation of oxygen radicals, necrosis and apoptosis in about 10 to 15 millimeter depth. So this is an example that I have for you, a patient with Klatskin tumor, bismuth 3, before photodynamic therapy. This is the picture. This patient was not eligible for surgery. Also, it was a bismuth 3 tumor because of infiltration of the hepatic artery. So what we did is a photodynamic therapy. You can see this is the situation. There is nearly no opacification of the left lobe. This is a very strong stricture. We placed stents to the left and to the right, but before doing so, we did a photodynamic therapy, and that is how it looked like after photodynamic therapy. It was possible from here to opacify the left lobe, which was not the case on this picture. So there is some effect. It is possible to bring in some local effects to the biliary obstructed bile duct due to Klatskin tumors. Of course, there are many studies, not many, but some studies that try to compare photodynamic therapy to stenting alone. The biggest one was Ortner Gastroenterology in 2003, and they could really nicely show that photodynamic therapy can increase the survival in patients with a Klatskin tumor significantly when photodynamic therapy and stenting were combined, while stenting itself was not as efficient. And even more, it seems that the bilirubin drops in the group A, which is photodynamic therapy plus stenting, significantly stronger than in the group only with stenting. So it is possible to offer these to patients, but as I said, it's really sophisticated technology. And this is a meta-analysis that also tried to put the studies together that compared photodynamic therapy versus stenting. And in all these studies, there is a benefit for patients with Klatskin tumors undergoing this sophisticated tool of technology. But photodynamic therapy is in progress. As I said, if you give the patients the photosensitizer, this drug basically accumulates in the whole body. So this is why the patients have to wear sunglasses and have to protect themselves from the sun, which is very difficult, particularly in the summer. But things are progressing, and this is the so-called PCI technology, which is a forward technology of the PTDD, which tries to bring in drugs that are marked here with liposomes. And if you give those drugs and they enter the cells, and you give them the wavelength of the laser, you can activate specifically this drug in the tumor cell, which is not activated in other cells because it is engulfed in so-called lysosomes. So this is the so-called PDT technology with a sophisticated technique to activate drugs specifically in tumor cells. And this is based on experimental data, all of them showing that it is possible to activate like chemotherapeutic agents, gemcitabine packed in liposomal vesicles with PCI technology specifically in tumor cells. There is a study running, and we are part of the study in Munich to see whether this has an effect in patients with Klatskin tumor. Of course, as the radiologist, they offer radiofrequency in most of the cases, but also the gastroenterologist is able to apply a radiofrequency in biliary obstructed tumors, and radiofrequency works very simple. It converts electromagnetic energy into heat and is able to destroy the tissue that is punctured by the needle. So this is something that we can also apply to the bile duct shown here. You have a special tube that you can place in the bile duct and activate, as I said, electromagnetic waves, transform them into heat and destroy the tumor cells in the bile duct, for example. This is something that is very fancy, interesting. It does not need a photosensitizing. You can directly do this, and this is how it looks like, and this is how it is placed into the bile duct, and you can go up to the obstruction and offer the patient some sort of local therapy. And I have here an example that clearly shows that it is possible to do such radiofrequency in a situation with a bile duct cancer. Here you can see the stricture. This is the hybrexa. You can see it's very, very tight. And this is this tube or the radiofrequency tube that you can place into the stricture. And the heat is produced between these two metal zones. And then you can apply here heat to the tumor with some effect on the stricture. And this is my last study that I would like to share with you, something that was done in our hospital comparing radiofrequency to photodynamic therapy, 14 patients receiving RFA or 20 patients receiving photodynamic therapy, and to be honest, it seems that it is equally good. There is a tendency towards the better outcome in patients having received radiofrequency ablation compared to photodynamic therapy. I'm not talking about life quality, so it seems that radiofrequency is something that we can offer to our patients. There are complications. Cholangitis is some complication that occurs in both of the cases, so there is no big difference in terms of complications when you apply radiofrequency therapy or photodynamic therapy. So the armamentarium of the gastroenterologist in the treatment of perihilar cholangiocarcinoma is there, and it has to be used wisely and according to the tumor that you face with. Is it a Klatskin 4, Klatskin 3A, 3B? You can use your armamentarium to treat these patients, but what is important in the management from a gastroenterologist point of view is you have to have the best stenting, the best drainage. You have to place bilateral stenting to get optimal stenting at least of all cholangiographic opacified segments. It seems that plastic stents are inferior to metal stents. PTBD is an alternative, at least in the hands of gastroenterologists. You should consider EUS-guided biliary drainage if it is not possible to access the papilla. You can do it via the duodenal bulb or even also from the stomach. You can combine it with local ablative procedures. We are now in the progress of improving these technologies, PTDD or RFA. We are now running a trial to test the efficacy of an improved technology of photodynamic therapy, which is called PCI. So these are the options that a gastroenterologist can offer, and I'm happy to see what the radiologist is able to offer in such a case. So if there are some questions, I'm happy to take them. Thank you for your attention.